Thank you, Mr. Kumbula, for the introduction. Morning once again. I'm going to take you through multiple pregnancies, care, and complications screening. Okay, so we'll start off with a background. Women with multiple pregnancies need special care. They don't just need palpation and sending them away. That care is insufficient for women with multiple pregnancies. It's not about saying you have a big abdomen. It's not about saying that I cannot feel the fetal parts correctly, maybe I'll see her next time. There are other things that cannot be felt by the hands, which can be ongoing in a woman with multiple pregnancy. So they need specialized care, and due to lack of that care, in most African countries, these women they've been experiencing more perinatal mortality and morbidity. In our institutions, there was no specialized training for scanning women with multiple pregnancies as well, basically because the lecturers were also not sure of what is supposed to be done. So because of this, Sub-Saharan Africa has the world's highest perinatal mortality in the under 5, and also neonatal mortality. And most of it is coming from multiple gestations, not just twins, but multiple gestations. So you can see on the right side, on the second bullet there, I put that Africa, Sub-Saharan Africa, has the highest perinatal mortality and morbidity. And especially in the age group of less than 5. And some of that is being contributed by multiple gestations because of the insufficient care. Because of that background, as the Fetal Medicine Foundation, we sat down and we discussed that what can we do so that we can bridge the gap. We can stop saying in Sub-Saharan Africa things are like this, perinatal mortality is like this. So in Zimbabwe, the story is now different because we have made progress. We are now doing something about the multiple gestations. What are we doing? We managed to establish multiple pregnancy clinics which are dedicated to scanning multiple gestations only. So there's a room and time allocated for just looking at women with multiple gestations. So these are 3 clinics, one at Parenyatwa Group of Hospitals and 2 at Salimu Gabe Central Hospitals. One of the clinics is manned by midwives who are seasoned in scanning multiple gestations. So they scan the ones that do not have any complications, they scan the newcomers, and then if they pick problems, they refer to the specialist clinic, which is manned by the specialist obstetricians and also the fetal medicine specialist. Okay, so what is important about multiple pregnancies? For us to give the specialized care that we talked about, what is special about these pregnancies is that we have to determine the gestational age properly, because the care, all the care is based on the gestational age. We have to establish the chronicity, because that's what is going to determine the complications that we should anticipate, the surveillance that we should give for that particular woman, and the fetal outcomes that we are going to have. Chronicity should be established as the first thing when managing a woman with multiple pregnancy, which is in the first trimester. We use the thickness of the intertwin membrane. We can also physically count the number of placental masses that are present. So the image on the right side there is showing a thick intertwin membrane, which is showing that it's a dichorionic pregnancy. This one is showing a thin intermembrane thickness, which is showing that it's a monochorionic pregnancy. So in the first trimester, these things are clearly visible. As the pregnancy progresses, it may be difficult to assess the intertwin membrane. That's why we are saying we should refer these women, or we should start to scan them in the first trimester so that we can assign the correct chorionicity. However, if they present in the third trimester, where it's difficult to assign chorionicity, when we are not sure, we should assign the most difficult, the most severe chorionicity. Like when we are not sure, is it a dichorionic or a monochorionic, we assign monochorionicity, because that's where most of the complications are expected. And it means if we do that, the woman is going to get the care that is supposed to be given for a monochorionic pregnancy. But if you say it's a dichorionic when it's a mono, you are inviting challenges for that pregnancy. Okay. So the gestational age, we establish it in the first trimester using the crown rump length of the bigger twin. If they are presenting in the second or third trimester, we use the head circumference of the bigger twin. We don't assign different gestational ages to two babies who are coexisting in the same pregnancy. These babies were conceived on the same day, and most probably they are going to be delivered on the same day. So we don't say twin 1, EDD, this, twin 2, EDD, that. We use the CRL of the bigger twin, or the head circumference of the bigger twin. All the things that Mrs. Zanga discussed on pregnancy dating also apply to multiple gestations. So I'm not going to get into the details of that. Okay, so we said we are starting in the first trimester. And when they come, what should we do for them? We should confirm the type of gestation. By now, we all know that when we say multiple pregnancies, we are not just referring to twins. It could be a triplet, quadruplet, quintuplet pregnancy. So in the first trimester, we establish the type of gestation. We establish the number of babies that are viable. We establish the pregnancy location. We assign chorionicity using the tools that I described in the previous slide. We label the fetuses using fetal position, fetal gender, placental location, or cord insertion position. The easiest labeling tool is fetal position. In our unit, we are using twin 1 for the fetus who is on the maternal right side. That is if the fetus is lying in a longitudinal fashion to the maternal long axis. If the fetal back is lying parallel to the back of the mother, longitudinally like that, and is on the right side, that one becomes twin 1. And if the other one is lying on the right side, also in the same fashion, that one becomes twin 2. If we have one baby who is crossing and is in the lower segment, and the other one is crossing and is in the upper segment, the one who's closest to the cervix becomes twin 1. The other one who is lying anyhow becomes twin 2. Things can be difficult, especially in the third trimester. You can use fetal gender to your advantage if we have a boy and a girl. But if they are of the same gender, obviously you cannot do that. You can also use placental location, especially in a monochorionic, monoamniotic pregnancy. Sorry, you use placental location in a dichorionic pregnancy. And then for monochorionic, monoamniotic, that's when you use the cord insertion position if things are difficult. So in the first trimester, we also screen for everything that Dr. Chirume talked about, the trisomy 13, 18, and 21. We also look for major abnormalities like holoprosencephaly, having in mind that multiple gestations have a more common risk of congenital abnormalities. Okay, and we also just assess for the presence of adnexal masses. So after the first trimester scan, we are now sure how we are moving. We are sure of the type of pregnancy that we are having and the chorionicity as well. In twins, we can have monochorionic or dichorionic twins. They can also be conjoined, but for the purpose of this presentation, I will not get into the details of that. We can also have triplets, which may have 3 placental masses, 2 placental masses, or even 1 placental mass. We can have quadruplets, quintuplets, and all the higher order pregnancies that we can get. In our unit so far, the highest order that we've managed was a quintuplet pregnancy. Okay, so for twins, we said we can have monochorionic or dichorionic. Monochorionic, we are saying we have 1 placental mass and the babies are sharing 1 placental mass. They can have 2 different amniotic sacs or 1 amniotic sac. The one that have 1 placental mass, 1 amniotic sac, those ones are very rare. At any given point, if you are assigning that title, you really have to be sure of what you are doing because it's very rare. So I'm going to talk about the monochorionic, dichorionic. We follow them up from 16 weeks, 12 weeks, then the next visit should be at 16 weeks, at which point we start surveillance for the complications that we should anticipate in a monochorionic pregnancy. The most common complications are twin-to-twin transfusion syndrome. Our registrar is going to present on twin-to-twin transfusion syndrome. We can also have twin anemia polycythemia sequence, selective fetal growth restriction, single intrauterine fetal demise, preterm labor, and the TRAP sequence, which is a rare occurrence. So, with these complications in mind, we see monochorionic pregnancies every week to actively look for these complications. So that's the reason why they are coming. If you are not able to screen for these complications, so it means you are not able to take care of a woman who's having twins. You have to refer. So when we see them, every 2 weeks, we are assessing fetal growth using the same biometric measurements that were mentioned by Mr. Zanga. We assess the biparatal diameter, the head circumference, the abdominal circumference, the femur length, and after we've done that, we obtain an estimated fetal weight for each baby. And then we calculate the discrepancy. The weight of the bigger baby, subtract the weight of the smaller baby, we get a difference. That difference divided by the weight of the bigger baby times 100. Then we get the percentage discrepancy. If that discrepancy is more than 25%, then it's significant. It's pointing towards something, either twin-to-twin transfusion syndrome or selective fetal growth restriction. We also assess the Doppler studies, umbilical artery, middle cerebral artery, ductus venosus. The amount of amniotic fluid we assess using the single deepest pool. So if you are a sonographer, don't report amniotic fluid index in women with twins, because you are not able to divide the abdomen into 4 like what you can do with a singleton. So you report a single deepest pool for each baby. You subtract the smaller measurement from the larger measurement, then you have the discrepancy. If it's more than 6 centimeters, it's also significant, and it's pointing to twin-to-twin transfusion syndrome. Okay. We assess the fetal bladder volumes at every visit. You have to visualize the fetal bladder filling for both babies, and you flight the images on the same screen so that you can compare real time. If you assess this one, then go to that one, your assessment may be subjective. But if you do it real time, you'll be able to see if they are comparable or not. Okay. So we also measure the cervical length. Dr. Verenga emphasized that we have to screen actively for preterm labor. So this group of patients have an increased risk of preterm labor. So the ultrasound scan is not complete until we measure the cervical length and identify if the cervical length is shortening or not. So we continue to see them like that, and then at the 18 to 22 weeks anomaly scan, again we have to remember that they have a higher risk of congenital malformations. So our assessment should be more detailed because they have a higher risk. After that, we see them every 2 weeks. Monochorionic pregnancies should have a detailed ultrasound scan every 2 weeks. And then we aim to deliver at 36 to 37 weeks if we don't have any problems. If it's a monochorionic, monoamniotic, we aim to deliver at 32 to 34 weeks. Okay, so our registrar is going to explain a little bit more on twin-to-twin transfusion syndrome. I'm just going to take you through on how we manage and the things that we look for. So it can start as early as 16 weeks, between 16 and 25 weeks. It complicates about 10 to 15% of monochorionic pregnancies. It's a severe syndrome with a prognosis of 18% if it's not managed well. So, what is wrong when we end up having twin-to-twin transfusion syndrome? We have one placental mass. Can you see my pointer? No. Okay. Can you see it now? Okay, so we have one placental mass, 2 cords that have been inserted anyhow, and they have blood vessels that are coursing throughout the placenta. In the end, we can have veins and arteries from twin 1 and twin 2. They may be close to each other. And it is known that if they are sharing one placenta, there is transfer of blood from one baby to the other. That is okay if the transfer is happening and it's balanced. But when we end up having a net transfer of blood from one baby to the other, it's like we are now having a donor and a recipient. So when that happens, we end up having the one who is donating, they will have hypovolemia. The one who is receiving will have hypervolemia. So the one with hypovolemia will have less fluid around them, less amniotic fluid, a smaller bladder, and they will fail to thrive. The one who is receiving more blood will have more urine because they are getting more fluid, more amniotic fluid around them, and they can get into heart failure because of the fluid overload. I'm trying to simplify things so that everyone can understand. These things are easy. Medicine is easy. It's just as easy as I have just explained it. So, what happens when one baby is giving the other one fluid? On scan, what are we going to see? The one who is donating will have a smaller bladder. The one who is receiving will have a bigger bladder. The one who is donating can have no fluid or less fluid around them, oligohydramnios. The one who is receiving can have polyhydramnios. And we say this one can fail to thrive. And then they can end up having abnormal Doppler studies. We can have the one who's receiving fluid getting hydropic, and one of them can die. In most of the cases, it's the one who is receiving. Simple, isn't it? Very. So, I was going through the Quintero staging system for classifying twin-to-twin transfusion syndrome. The word is confusing, but what I have explained is what is represented by the Quintero staging system. Stage 1, we have just differences in the amniotic fluid volumes. Oligohydramnios, polyhydramnios. Stage 2, that's now when we have the differences in the bladder fillings. Small bladder, big bladder. Stage 3, abnormal Doppler studies in the umbilical arteries. Stage 4, that baby becomes swollen, fetal hydrops. Stage 5, we can have single fetal demise. Management. In our setting, we are not able to perform laser ablation, which is the management of choice, because laser ablation is just going to ablate the anastomosis that is happening between the two babies right at the equator, and the problem will be solved. But in our setting, we are not able to do that. We rely more on conservative management if it's mild. If you are having polyhydramnios, loss of discomfort in one of the sex, we perform serial amnioreduction. That can relieve the signs and symptoms of polyhydramnios. We do that for stage 1, stage 2, when we are less than 26 weeks. When things are getting bad, we are more than 28 weeks, more than 30 weeks, we can plan for delivery. Okay, so the next important complication that we can have in monochorionic pregnancies is selective fetal growth restriction. In this one, we have one placental mass, as you can see in this image. At condensation, one of the babies inserts more centrally than the other one, who inserts at the little peripheral corner. Obviously, this one will have a more established vasculature that will occupy about 75% of the placental mass, meaning that they are getting about 75% of oxygen and nutrients. Well, this one will only remain with maybe 25% or less. This one will end up failing to thrive. When do we say there's selective fetal growth restriction? After we have assessed the estimated fetal, we have obtained our measurements, we have our estimated fetal weight, we do our subtractions, smaller from bigger weight, divided by bigger weight times 100. The percentage, if it's more than 25%, with no amniotic fluid discrepancies this time. Are we together? no fluid discrepancies, then we say this is selective fetal growth restriction. We can also have one of the babies with an estimated fetal weight falling beneath the 10th centile. Just that is also diagnostic of selective fetal growth restriction. We can have one of the babies with an umbilical artery PI that is more than the 95th centile. That in itself is also diagnostic of selective fetal growth restriction. So we use those three criteria to pick selective fetal growth restriction in monochorionic pregnancies. Once we pick this, we follow them up every 2 weeks, assessing the estimated fetal weight and the Doppler studies. At this point, we'll be monitoring the deterioration of the fetal condition. Once we see that the baby's condition is deteriorating, we advise delivery. And then, if things are going on well, we can wait until 34 to 35 weeks, and then we advise delivery. What else can happen in a monochorionic pregnancy? One of the babies can die. For all the reasons that we have talked about, selective fetal growth restriction, twin-to-twin transfusion syndrome, TAPS, you name it, one of the babies can die. Once that happens, in a monochorionic pregnancy, we can end up losing both babies. But we don't order delivery immediately. We do objective assessment by way of using the Doppler studies and also a CTG. So we see them every week until they have stabilized, assessing the Doppler studies. Once they stabilize, we can start to see them every 2 weeks, assessing fetal growth and Doppler studies. And then the timing of delivery is at that point when we notice that the survivor is deteriorating. Or if we are able to push the pregnancy to 34 or 35 weeks, then we deliver at that point. So we don't say one of the babies has died, we are taking you to theater to remove one baby, and the other one will remain. We have seen women who were managed like that. So we are not going to be doing that. We are going to refer, we monitor, and then we deliver when it's indicated. Okay. Twin anemia polycythemia sequence is a younger brother of twin-to-twin transfusion syndrome. In this case, we have the same placental mass, the blood vessels that I flighted on the previous slide, but in this case, we have small arteriovenous anastomosis of a very small caliber, which are deep-seated, causing chronic, slow movement of red blood cells from one baby who becomes the donor to the other baby who becomes the recipient. Because it's just red blood cells, slow and chronic, we are not going to have differences in the plasma volume. So we are not going to get the differences in the amniotic fluid volumes that I described earlier on. Rather, we are going to pick this condition on Doppler assessment of the middle cerebral artery. Mr. Zanga described where we find the middle cerebral artery and how this assessment should be done. So in this case, we are looking at the middle cerebral artery peak systolic velocity. In simpler terms, we are assessing the speed at which blood is flowing across the middle cerebral artery in both babies. If the flow is slow, it means there is sluggish flow. Why? Because there is an overload of red blood cells. So the peak systolic velocity is going to be low in that baby who is the recipient in this case. In the other baby who is the donor, they are going to have less red blood cells in their blood, and blood will be moving at a faster rate. We are going to have a higher mean peak systolic velocity in the donor who may be having anemia already. So we are going to flight these measurements on the same graph, and we can see that this one is having a lower peak systolic velocity, that one is having a higher peak systolic velocity, and we diagnose TAPS. Okay, in the interest of time, I will move on to TRAP sequence, a rare occurrence where we have one of the twins not having the torso or poorly developed torso, and this baby will be transfusing the other one. The most important finding on ultrasound scan is a mass in the baby. So if you see a mass in the baby, you have to refer, because in most of the times it will be a TRAP sequence. Okay, in the interest of time, I'll move on to dichorionic twins. These ones, we see them in the first trimester. If everything is okay, we've done everything that is supposed to be done, we'll see them again at the 18 to 22 weeks fetal anomaly scan. And again, we'll perform a detailed ultrasound scan in view of the increased risk of congenital malformations. If everything is okay, we see them every 4 weeks now. We've moved from 2 weeks to 4 weeks. We will be assessing the fetal weight, Doppler studies, and the cervical length every 4 weeks. The timing of delivery is, if it's uncomplicated, is at 37 to 38 weeks, and we should not exceed 38 weeks. Common complications include selective fetal growth restriction, single intrauterine fetal demise. In this case, it may be due to selective fetal growth restriction, discordancy for congenital abnormalities. Those are the things that can cause single intrauterine fetal demise in a dichorionic pregnancy. They are also at a more increased risk of having preterm labor and preeclampsia because of the increased placental surface. Once we pick selective fetal growth restriction, we should see them every 2 weeks. We have changed from 4 to 2 now, if there is selective fetal growth restriction, where we'll be checking the fetal growth and Doppler studies. If the fetal condition is deteriorating, we advise delivery. If everything is okay, we monitor until 34 to 35 weeks. If we have single intrauterine fetal demise in a dichorionic pregnancy, the outcomes are better compared to a monochorionic pregnancy. So these ones we also monitor every week until they have stabilized, and then we start to see them every 2 weeks and aim for delivery at 34 to 35 weeks. Okay, so for all the twins, the mode of delivery, in our units we are saying the safest mode of delivery for twins is cesarean section, a planned cesarean section, because we can have them presenting in all sorts of presentations. And we know that even if the leading is cephalic, there's need for manipulation for the delivery of the trailing twin. And this manipulation is no longer being trained properly in our units. And The experienced obstetrician who is needed for this delivery may not be present at that point, and we end up having one of the babies either dying or developing cerebral palsy. So we advise delivery by planned cesarean section. For triplet pregnancies and higher order, we start in the first trimester. We do everything that I mentioned. Every 2 weeks, we assess growth, Doppler studies, and the cervical length, we do it every month. We perform a detailed second trimester scan. The common complications, we can have selective fetal growth restriction, twin-to-twin transfusion syndrome, single intrauterine fetal demise, preterm labor, all the complications that we discussed earlier on. Timing of delivery for triplets is 32 to 34 weeks. For quadruplets is 30 to 32 weeks. That will be the end of my presentation. Thank you.